Good evening. Thank you for joining us. My name is Dr. Angela Weyand, and I'm joined by my colleague, Dr. Guy Young, to talk about practice-changing updates, the evolving hemophilia treatment landscape. This is a continuing education webcast with enduring archive and podcasts. So just to start with some of our disclosures, these are my disclosures listed below. And these are the disclosures for my colleague, Dr. Guy Young. The learning objectives for this activity, participants should be able to appraise the clinical utility of recently approved therapies for severe hemophilia A. You should be able to employ patient-centered strategies to adequately switch and optimize recently approved therapies in order to enable improved outcomes for our patients with severe hemophilia A. You should be able to recognize the rationale and mechanisms of action of these emerging therapy approaches, and as well as evaluate recent clinical evidence on emerging therapy approaches and identify patient subsets that can benefit from these novel agents. So to start, I'm going to be speaking first on replacement and non-replacement therapies for hemophilia A. As probably most of you are aware, the treatment of hemophilia A has really evolved over time. Looking back to the 50s, when the only thing we really had was plasma, then in the 60s, cryoprecipitate, followed by PCC and APCC treatments. And then in the 70s, really a big, shift in treatment with the development of plasma-derived factor VIII concentrates. Also in the 70s was the DDAVP, and then later in the 80s, luckily, after there were issues with viruses in the plasma-derived products, we had viral inactivation in the mid-80s for our products. But it really wasn't until the early 90s that we started to have availability of recombinant factor VIII products. And there has been evolution in this as well, with second and third generation factor VIII products coming in the early 2000s. And then in the mid-2000 teens, extended half-life factors being approved and available. We know that then, we've also had the development of non-factor products, including mimetics, as well as rebalancing therapies against our body's natural anticoagulants in the 2020s. And those products are either still in development or some recently approved. So thinking about factor VIII replacement therapy in hemophilia A, I think we all are, aware that there are pros and cons to the use of factor replacement. I think the big pro is that we really are replacing what the patient is missing. We have the most experience with these products because we have a long history of using these. Going back decades, we know that they are relatively safe, although we do need to be aware that with all of these products, there is the risk of development of autoantibodies and inhibitors. We know that we can get peak levels into the normal range and can follow these levels and know really where our levels of factor VIII and hemostatic control are. We're able to give extra doses, and we're able to use the same product for prophylaxis as well as to treat bleeds or to perform surgical procedures or things that need extra hemostatic efficacy. There are cons as well, and I think our patients are probably even more aware of these than we are. They do require intravenous administration, which can be quite difficult, especially in our youngest pediatric patients. They have required 2 to 4 times per week administration, which really is quite a large burden of treatment, especially when you think about that intravenous administration. So these things together can make it difficult for our patients to adhere to their treatment plan. And many young patients, usually our youngest patients that have difficulty with intravenous administration, need ports, which come with their own risks, including infection and thrombosis. We know that factor levels do fluctuate and that when the levels come down at the end of the treatment interval, when patients are at those trough levels, there is bleeding risk at that point. So these are all things to take into consideration when we're thinking about whether patients should be receiving factor replacement therapies versus some of these newer products. So, as I mentioned, even when we think about factor VIII replacement products, there has been evolution of factor VIII products over time. Back in late 1960s, early 1970s, we had plasma-derived clotting factors. And then, as I mentioned, in the 1990s, were the first recombinant clotting factors. And this was really very exciting, given the fact that there had been widespread viral contamination, and recombinant products really eliminated this potential for transmission of bloodborne pathogens. Then, many of you are probably aware, as we recognize this really high burden of treatment on patients, many companies looked to develop products that had more extended half-life that could be dosed less frequently. And so a lot of these extended half-life clotting factors were developed. And they did lead to, for some patients, to fewer infusions with similar outcomes to the standard half-life factor products. Similar to the extended half-life, they were safe products other than the risk of inhibitors, and are effective for surgery, prophylaxis, and treatment of bleeds, but still had quite, an high treatment burden, even with the extended half-life products that really weren't able to extend the half-life quite as long as we would have liked to. And we know that patients still continue to have bleeds on these products, so we're not able to fully prevent arthropathy. And there's also a pretty significant cost associated with all of them. So thinking about extending the half-life of factor products still within the realm of factor replacement products, there has been a significant extension of the half-life of factor VIII with the development of efanesoctocog alpha. So efanesoctocog alpha is a very highly modified recombinant factor VIII product that utilizes a number of different modifications to extend its half-life. So similar to some other extended half-life products, it has the Fc receptor to increase the half-life through that recycling pathway. There are two extend molecules that also increase the half-life. But probably the biggest thing is this D' D3 domain that is present, that is there basically to decouple the infused factor VIII product from the patient's endogenous VWF. As we've learned that VWF is really limiting the half-life of the infused factor VIII, and decoupling the factor VIII that's infused from the endogenous VWF can really extend the half-life greater than what had previously been able to be achieved. And so with this, in the Extend 1 trial, looking at patients who'd previously been treated with factor VIII products, they had a lead-in study where patients received what, between themselves and their healthcare providers had been determined to be an optimal factor VIII treatment regimen. In the pre-study, their ABR was 2.96, and then they entered into the study and got standardized dosing of 50 international units per kilo once weekly of efanesoctocog, which actually decreased their ABR by 77% down to an ABR of 0.69 on once weekly prophylaxis. And obviously with this pre-study prophylaxis, these patients were receiving infusions much more frequently, between 2 and 4 times a week, but still with much less treatment burden, had a pretty significant decrease in their mean ABR. And as expected from data that we had from earlier trials, with these modifications of the factor VIII molecule, there really was pretty significant extension of the half-life. So this is pharmacokinetic data from the Extend 1 trial, which shows, we're still achieving very high normal levels of factor VIII after infusion, that then obviously decrease over time, but out at that 7-day interval when patients are about to infuse again, really still are in the 12 to 15% range, and patients are actually above this kind of 40% normal level for over half of the week. So a much longer half-life, allowing for this once weekly dosing, still with troughs much higher than patients have been able to achieve with other factor VIII products. Oh, sorry about that. So looking at some more data on efanesoctocog alpha. There was also the Extend Kids study, which looked at children, again, with severe hemophilia A. These were also previously treated patients, but they went down to, less than 6 years of age. It was 0 to 12 years of age patients, and patients, again, received the standardized dosing of 50 international units per kilo once weekly. And as you can see, the median ABR was quite low at 0. And the mean ABRs, the overall was less than 1. 6 to 12 was a little bit higher, and less than 6 was a little bit lower. I would hypothesize probably due to the kind of level of activity in the patients of varying ages. But really the primary endpoint in the study, primary outcome, was the incidence of neutralizing antibodies to factor VIII, and there were no inhibitors that were detected with the trial. It, similarly to the adult study, did show that the vast majority of bleeding episodes were able to resolve with 1 50 international unit per kilo injection, and that the vast majority of bleeds that were treated, the response was rated as either excellent or good by the patients. There were two patients who had 2 major surgeries during the trial, and their hemostatic response was also deemed as excellent. So overall, data pretty consistent with the adult data, showing low ABRs and good responses to just 1 injection as far as bleeding treatment. And then looking at the pharmacokinetics in children, most of you are probably aware that younger patients tend to require more frequent dosing and have lower troughs than adults, and that is what we see here. So, but again, much extended half-life compared to other products, getting, those normal factor levels after infusion, and then going up to day 7 when patients are redosing, having trough levels in the 6 to 7% range. So still ending up with patients being above that 40% or normal level for a little less than half the week, but still, remaining quite high even towards the end of the week. So we're going to go now to our first polling question, which will be about some of the things that we just discussed. So which of the following are true for efanesoctocog alpha? A, it is a factor VIII replacement therapy. B, it is designed to decouple recombinant factor VIII from endogenous VWF or von Willebrand factor and overcome the VWF imposed half-life ceiling. C, it could be provided as a once weekly intravenous infusion. D, all of the above. Or E, none of the above. So looking at the results, I think everyone is brilliant in the audience, with 100% of our participants choosing all of the above. So yes, it is a factor VIII replacement therapy. It has the extended half-life, largely due to the decoupling from endogenous VWF, and it can be provided as a once weekly intravenous infusion. Great job. So moving on to kind of the next product that we wanted to talk about is the first non-replacement agent that we'll discuss this evening, which really, when it was approved, allowed us to overcome a number of the limitations that we know are present with the use of factor therapy. So we know that the missing protein in hemophilia A is factor VIII, and that really the action of factor VIII, activated factor VIII, is really to bring together activated factor IX and factor X on the phospholipid membrane. And so the thought with emicizumab, which is the first factor VIII mimetic that has been approved, there are others in development, but emicizumab has been available for a number of years and really acts to mimic this action of factor VIIIa by bringing together activated factor IX and factor X, again, on this phospholipid membrane, to fill the role of factor VIII when it is missing. And because it is not a factor VIII molecule. One benefit of it is that it can be used in patients with and without inhibitors. It can only be used for hemophilia A, as you would imagine. It's still mimicking the action of factor VIII, and so would only be effective in those patients that are missing factor VIII. Its pharmacokinetics are very different than factor replacement in that there are no peaks or troughs, and you have much more steady state hemostatic coverage. So you're not able to get that 100% factor VIII equivalence, but you also aren't, dropping down to a lower level before you get your next dose. And then additionally, one huge benefit that we've seen, especially in the pediatric population, is its subcutaneous dosing for administration. And so it doesn't require intravenous administration. It can be quite helpful in avoiding the placement of ports that I mentioned earlier that can be challenging in our youngest patients, as well as some older patients, but tends to be more of an issue in our youngest. So imicizumab has been studied in a number of different settings, and this is kind of a pooled analysis of long-term results from the phase 3 studies, so the HAVEN 1 through 4 trials in people with hemophilia A, looking at annualized bleed rates. And so as you can see here, this is a treatment interval over time, so 1 to 24 weeks all the way out to 121 to 144 weeks. And as you can see, kind of earlier on, the ABR is a little bit higher, but then as you get further out, it is quite low, less than 1, and is pretty consistent. And this shows here the percentage of patients with 0 and 1 to 3 treated bleeds, the percentage of those patients, again, over certain treatment intervals. And as you can see here, similar to a little bit higher ABR to begin with, and then dropping down to more steady lower levels. You can see here that initially about 70% in that first 1 to 24 weeks had 0 treated bleeds. And then that increased and was pretty steady at a higher level at those longer treatment intervals. But, with this, nearly 3 years of follow-up, these low bleeding rates are maintained. And the imicizumab is also very well tolerated over this longer term follow-up that has been done. So looking specifically at the different HAVEN studies, this is looking at patients who had 0 treated bleeds in a number of different settings. So the very first HAVEN study was just done in patients with inhibitors, specifically adolescents and adults with inhibitors, and looked at once weekly dosing prophylactically, and 63% of those patients had 0 bleeds. The next study, HAVEN 2, again, only looked at inhibitors, or patients with inhibitors, but went down to the pediatric ages and again looked at once weekly dosing, and 86% of the pediatric patients had 0 bleeds. Then the later studies looked at patients that didn't necessarily have inhibitors. So HAVEN 3 was a study of adolescents and adults without inhibitors, and looked at both weekly as well as every 2-week dosing, and had 56% of patients in the Q weekly dosing group that had 0 bleeds, and 60% of those in the every 2-week dosing group that had 0 bleeds. And then lastly, HAVEN 4 actually looked at every 4-week dosing, so approximately once a month, and looked at adolescents and adults. These could be patients with or without inhibitors, and even going out to that once every 4-week dosing, 56% of patients had 0 bleeds over the course of the study. So this brings us to our next polling question. Imicizumab has been studied among pediatric patients, so ages 2 to 11 years of age, with severe hemophilia A in which of the following trials? HAVEN 1, HAVEN 2, HAVEN 3, or HAVEN 4? And now there's been even more HAVEN trials, but just looking at those first 4. Perfect. So HAVEN 2 is the correct answer. So the HAVEN 1 was patients with inhibitors that were adults and adolescents, versus HAVEN 2 was, again, patients with inhibitors, but was in the pediatric studies. And then Haven 3 looked at those different dosing regimens of once a week and once every 2 weeks without inhibitors. And then Haven 4 was looking at that once every 4-week dosing interval. So we're going to talk about a few clinical case scenarios and kind of looking at these two different options that I've discussed already. So this is a 10-month infant who, as he is becoming more mobile, crawling and maybe pulling up to stand, maybe even trying to walk, has developed bruising and a large goose egg after stumbling into the coffee table. He had been diagnosed at 6 months of age, and unfortunately was the first person in his family with hemophilia. He has severe hemophilia. And being the first person in his family, he doesn't have family members that are really educated about hemophilia or necessarily, well-versed or trained in intravenous administration of medications. So, as his healthcare provider, you're called after he stumbled into the coffee table, has this large goose egg, and you decide that it would make sense to treat him given this trauma and provide him 1 dose of intravenous factor VIII replacement that they come in to infusion for because they don't know how to infuse at home. But now the family, they've met some other people with hemophilia. They understand the idea of prophylaxis. They're a little more nervous as he's becoming more and more active and is already bonked himself on the head with the coffee table. So they're asking about prophylaxis and when they should be starting that, but they're really not feeling great about the idea of doing intravenous treatments at home. As I mentioned, him being the first in the family, none of them have done intravenous administration, and they are non-medical and not too interested in learning. So with this, we'll do another polling question, thinking about for this young infant who, we know is just going to be more and more mobile and be more and more at risk for bleeding, not only with his head bonks, but also into his joints. What would be the best practice approach for this patient? So, as I mentioned, they're not confident about IV treatments, and they also have heard about all of the risks associated with ports in terms of infection and thrombosis and complications related to having a port. So they also would like to avoid that if possible. So should we, A, educate and train the family about intravenous factor VIII prophylactic therapy? Say, well, you're going to suck it up. This is what we do. Your baby has hemophilia. You're going to have to learn. Should we, B, provide standard half-life factor VIII therapy? C, provide extended half-life factor VIII therapy. D, provide efanesoctocog alpha, or E, provide emicizumab. So the vast majority of people felt like we should provide emicizumab. And I think that is a really, what a lot of us would do in this situation now that we have that as an option. I think that previously when we didn't have that as an option, we would, probably a lot of centers would have placed a port in this infant or, try to start intravenous prophylaxis without a port and see how that goes. And some would eventually end up with a port. But I think now that we have this option, this can be really nice for families when their children are very young and intravenous administration is very difficult and can help avoid ports in that situation. So what do we know about using emicizumab in infants? There is a study, as I mentioned, we have additional Haven studies, and the Haven 7 study was on infants with severe hemophilia A without inhibitors. And this is data from the interim analysis. So this looked at efficacy, safety, pharmacokinetics, and pharmacodynamics. Participants had to be less than 1 year of age and have severe hemophilia A, and they received the typical loading dose for 4 weeks of emicizumab, and then received every 2-week dosing of emicizumab for 52 weeks. And at that point, they could either continue with that regimen or switch to either a weekly regimen or an every 4-week regimen for this 7-year long-term follow-up period. And what they found on interim analysis was 77 bleeds occurred in 31 patients. The vast majority of them, so 88%, were traumatic. There was 5% that were procedural or surgical, and 6.5% that were spontaneous. None of the patients experienced adverse events that led to treatment withdrawal, modification, or interruption of any type. So it seemed to be safe, and also seemed to be effective among the infants. And then, PK and PD and pharmacokinetic activities were sustained. So, some data, and I know there will be future data coming out of this trial as well, as this is interim analysis, but some data to reassure us that this is a safe and effective option for these infants. So with that, I think, providing emicizumab is a good option for these patients, and, would be something to be able to offer this family. So maybe we'll repeat the polling question and see if anyone has any changes of opinion. I think already we had the vast majority of our audience choosing to provide emicizumab, with one audience member preferring to educate and train the family with intravenous prophylactic therapy. But we can see if there is any change in our answers. And our results are back with 100% of the audience providing emicizumab, reassured by that data. So with this, starting emicizumab, the family obviously needs to still be trained and educated about subcutaneous therapy. It is easier than intravenous. They still will require factor VIII for on-demand treatment of bleeding and around any surgeries. There's not really routine laboratory monitoring that's required, but if you are checking levels, chromogenic assays need to be used rather than one stage. And as with any of our patients, especially young patients who haven't received a lot of factor VIII therapy, ongoing monitoring for inhibitor development is indicated. So thinking about another case, in this case, we have a 14-year-old boy who's a competitive swimmer, and who unfortunately has had several joint bleeds following intense activity periods when he's in season and competing and doing higher level swimming. He's currently on prophylaxis with an extended half-life factor VIII product, but despite the fact that it is extended, still is requiring infusions 3 times a week. He is interested in having a product that he's able to achieve high levels of peak protection, given his high levels of intense activity, but he's pretty frustrated that he's continued to bleed despite infusing 3 times a week, which hasn't been the best thing for him in terms of fitting that into his schedule. So we'll start with a polling question. For this patient who's a competitive swimmer and would like high peak levels, but is frustrated by his current 3 times a week burden of treatment, what would be the best practice option or best practice approach for him? A, recommend reducing swimming to just once a week. B, say stop swimming. C, switch to emicizumab. D, switch to weekly efanesoctocog alpha. Or E, suggest he gets treated with gene therapy. All right, we have a few different ideas. So we had about half of the group that felt like switching to emicizumab would be helpful. And that would be helpful definitely as far as his burden of treatment. We had about a third of the group that felt like switching to weekly efanesoctocog alpha, which also would be helpful for burden of treatment. And then one respondent who felt like gene therapy might be a good option. So in this case, we actually chose to start on prophylaxis with once weekly efanesoctocog because remember, this was a patient who is doing very high level activity and was having a number of bleeds and would really like to be able to get high peaks that he wouldn't necessarily be able to get with a non-factor product like emicizumab. So he was started on prophylaxis once weekly with that standard dose. He would infuse just prior to his first swim practice and typically would have actually Sunday as his off day. So when he's hitting that trough, that still is pretty high. that's the day that when he's lowest, that he also is not as active. These patients, as any patients with treatment with factor VIII, should be monitored for development of inhibitors. In the case of efanesoctocog alpha, chromogenic assays are not recommended, but one stage are. And then he also would be able to use that same efanesoctocog alpha for any treatment of breakthrough bleeds. So kind of wrapping up some of the teaching points from these two options and from this patient as well. Once weekly efanesoctocog alpha has been associated with superior bleeding prevention compared to the prior factor VIII prophylaxis for those patients in the Extend-1 study. Normal to near normal factor VIII activity for over half of the week, and improvements in physical health, pain, and joint health. The introduction of efanesoctocog alpha has significantly reduced the number of infusions required for someone receiving factor VIII prophylaxis for severe hemophilia A, and has also been shown to be effective among children in the Extend Kids trial. Emicizumab, on the other hand, is a factor VIII mimetic that is effective in hemophilia A patients of all ages and can be used in those patients that have inhibitors and those patients that do not have inhibitors. So with that, I will hand it over to my esteemed colleague, Dr. Young, who's going to talk to you about a few other treatment options in that landscape.
All right. Thank you, Angela, for that. Very nicely done on that long section there on mostly factor VIII. So we're going to talk about a novel non-replacement therapies and gene therapy. And I think that one of the things to think about is also the disease burden. So I think about things as the disease burden and the treatment burden in hemophilia. And the disease burden is really about bleeding and the after effects of bleeding. So as you see here, we have pictures, patients of mine. Things start out with like an acute hemarthrosis, which could develop into a target joint. Then you see the boy with the blue sock to the right where it says synovitis. Eventually, you can develop synovitis if that target joint is not dealt with. And then ultimately, you'll end up with end-stage arthropathy, as you see in the bottom photo. I think you can see that the knee there on the patient's right knee has got really no landmarks and the atrophy below the knee. And what we found is that bleeding rates in patients on prophylaxis still are between 2 and 6 per year in the clinical trials. So if you look at all the clinical trials of the factor VIII molecules that have come to the market recently, other than Altuviiio that you just heard about, that you typically see 2 to 6 bleeds per year is the ABR. And that's probably because their half-lives are not long enough, and you end up with a trough level, maybe around 1% or maybe as high as 4%. The other important issue is that subclinical bleeding certainly does occur. And to the extent that there's overt bleeding, you can count on the fact that if you see overt bleeding, as in measured by the ABR, you'll also must have some situations of subclinical bleeding that'll make things worse. And the other aspect I often think about is the treatment burden. What is the burden of the treatment itself to prevent the bleeding? And of course, Angela went through some of the history, talking about the fact that intravenous clotting factors have been really the mainstay, but their issue is that they are intravenous, often multiple times a week. Even with the extended half-life factor VIII, it's 2 times a week, maybe every 3 days even, or maybe every 4 days, but typically not less than that. And this, of course, negatively impacts quality of life. And so here's a picture that a father sent to me of his son, where he showed me 3 Band-Aids, 3 bandages, and he told me that that was for 1 infusion, which really set me back a little bit, and I had to call him and tell him not to do Pocasun 6 times just to try to get the 1 dose of factor in. And his response was, well, Dr. Young, if I don't get the dose of factor in, then he's likely to bleed. So yeah, you can be in a really tough situation, as you see in that boy there. So let's take a look at the mechanism of action of the novel therapies. And we've heard of some of these already, and I won't reiterate them, but just as a sort of a global view, in green will be replacement therapies. You've heard about that. And substitution therapies, you've heard about those. I'll be talking about rebalancing agents, but just so we can see the whole picture, there's efanesoctocog alpha, where I work in the coagulation cascade that I've shown you here. This is where emicizumab and the follow-on mimetics or substitution therapies that are being worked on, MyMate and NXT007 that are in clinical trials. And then what I'll be talking about is rebalancing agents. So we're going to talk about fitusiran, which is an inhibitor of antithrombin. Notice the dashed line means inhibitor. So we're inhibiting an inhibitor. Concizumab, marstacimab, and the later stage MG1113. These are inhibitors of tissue factor pathway inhibitor, which in itself is an inhibitor, of course, of the tissue factor pathway. Serpin PC is an inhibitor of activated protein C, and not yet in clinical trials, but in clinical development, at least I don't think these are in clinical trials yet, are inhibitors of protein S, which by their mechanism of action also inhibit tissue factor pathway inhibitor. And then I will touch on, just briefly, gene therapy for hemophilia A here, factor VIII. There's gene therapy for factor IX, but we won't be really talking about that today. So here's the sort of issue of the rebalancing. So if we look at figure A, that's normal hemostatic balance. You see that the seesaw, if you will, are of the same numbers, and so the seesaw is balanced. If you go to B, which is below that, we've taken off some of the procoagulants. So imagine we took off, 3 balls, which are factor VIII, just as an example. Then you end up in a bleeding situation. It's tilted towards more bleeding. If we, in figure C or panel C at the top right, if we have hemophilia and then we add a procoagulant protein, be it a factor VIII or emicizumab, this is showing like factor 7A as well, as if it was inhibitors, we can start to rebalance things. But the other way to rebalance things is to have a situation of hemophilia and take away one of the coagulation inhibitors, or remove them or block them, such as fitusiran or TFPI inhibitors. And that's what we'll be talking about. And that's what I mean by rebalancing. Advantages of the rebalancing agents are that because they are not working specifically on a factor, they're not a factor replacement, they're not a factor substitute, therefore they can work in patients with hemophilia A and B, and it doesn't matter whether those patients have inhibitors, because of course the inhibitors are specifically to the factor proteins. So these could be sort of a pan-hemophilia drug, if you will, regardless of the type of hemophilia or the presence of inhibitors. There's multiple mechanisms of action of these, which may be more advantageous. So one mechanism might be more advantageous in some patients over others. They can be used in different types of patients as a result of that. They've been shown to be efficacious. I'll show you some data on that. They've been shown mostly to be safe. There have been thrombotic issues, so I have that on the con side. There are some safety concerns about thrombosis, but by and large, they've been largely safe for the patients. They're all administered subcutaneously, and not part of this talk, but they potentially could be used to even treat other bleeding disorders apart from hemophilia. The downside is that it's a novel mechanism of action, and you will have to learn about things like tissue factor pathway inhibitor that you might have taken for granted. I think antithrombin and protein C, most hematologists are familiar with, but still understanding the detailed mechanisms of protein C. So for example, it's really activated protein C that Serpin PC is inhibiting, not actual protein C. So little nuances like that can become important to understanding the drug's mechanism of action. Therapeutic drug monitoring with dose adjustments will be required, at least for some of these rebalancing agents, as we've seen in some of the clinical trials. There still are safety concerns, and there have been thrombotic events with most of these, although again, there's been mitigation strategies to try to eliminate those. And while some of these have an antidote, others do not have an antidote. So like if you do get in trouble with thrombosis with a antithrombin drug, well, we do have antithrombin to rescue the patient. But if you have the same situation with an anti-tissue factor pathway inhibitor drug, there is no tissue factor pathway inhibitor molecule that you can infuse to rescue the patient. So these are just a table looking at some of the properties. The mechanism of action, I already went through that in the previous slide with the coagulation cascade, so I won't reiterate that. You see the names of some of the drugs, which we've mentioned already as well. Dosing, you can see for fitusiran, it's going to actually be initially subcutaneously every other month, and it may increase to every month, but not more than once a month. Concizumab, on the other hand, is a subcutaneous daily injection. Now, there is a fancy little pen device that makes things a lot easier to try to mitigate against the fact that this is daily. Marstacimab is weekly, and the anti-APC, they're still working out some of the dosing, but likely it'll be similar to what you've seen for emicizumab with weekly, every other week, or every 4-week dosing. And then if we just, again, take a look at overall novel therapies, for hemophilia, I made this table looking at like infusions per year, just to kind of give a sense of how that works. So factor replacement is as, either weekly as efanesoctocog is, or some of the factor nines, or every other day. So between 52 and 183 IV injections per year. Emicizumab, as you've seen, is either once a week or every 4 weeks, so 13 to 52. The issue there is a long washout and there's no antidote. So once a patient has these drugs on board, if you don't like how it's affecting the patient, there's not much you can do about it other than wait. Fitusiran, 6 to 12 subcutaneous injections a year. In fact, the initial dose is every other month. Again, a really long washout. Now, there is an antidote in terms of antithrombin infusion, but that has a short half-life. So if you really need to reverse a patient, you're going to have to be giving IV antithrombin quite a bit. Fortunately, in the trials, that was hardly ever needed, so it's not like it's been a common theme in the trials. Concizumab is daily, so that's 365 subcutaneous injections. Unless it's next year, which is leap year, it would be 366. But again, it does have this advantage of a rapid washout, so that's a bit different. And then morstacimab and Serpin-PC, we've already sort of mentioned their dosing. So let's take a look at some data. This is data from the Atlas AB trial. This was a trial in patients with hemophilia A or B, as the title indicates, but who do not have inhibitors, so no inhibitors. And in this trial, there was a comparison group that was on demand. Now, you might say, well, in the US, we don't do that, and that's true, that we wouldn't have this trial in the US, but this trial is conducted around the world. Keep in mind that there's a lot of patients around the world that don't have access to prophylaxis. In the green bars is the annualized bleeding rate as a median of all bleeding events, treated bleeds, treated spontaneous bleeds, and treated joint bleeds as you go from left to right. Fitusiran is that sort of teal color, that bluish teal color that you see there. And at that time, when these trials, the dosing was 80 milligrams subcutaneously once per month. I think it's pretty obvious as you look at this that Fitusiran essentially stopped almost all the bleeding. Only all bleeding events even had a median that could be recorded. And those were bleeds that were not treated, because you could see treated bleeding events, the median was 0, so more than half the patients had no bleeds. Same with treated spontaneous joint bleeds and treated joint bleeds. Focusing in on the Atlas INH trial, so this was designed the same way as the Atlas AB trial. This was inhibitor patients. And here, on-demand therapy is actually more common with inhibitor patients. Although we do have prophylaxis for Hem A with emicizumab, as you heard earlier, we don't have for Hem B. And a lot of this work was done before emicizumab was broadly available. What you see on the right side is the percent of patients with 0 bleeds, 5.3%, so 1 out of 17 patients, or 19 patients who were on bypassing agent on demand had 0 bleeds, but with Fitusiran, 66%, almost 2/3 of those had 0 bleeding events. And in the table, if you look at the mean ABR, it went from 18.1 for bypassing agents on demand down to 1.7, and the median from 16.8 to 0. So clearly, Fitusiran was really effective at preventing bleeding events. We jump to concizumab. This is the EXPLORER-7 trial. So this includes patients with hemophilia A and B with inhibitors. We'll talk about the other trial without inhibitors. It's patients with inhibitors. I don't have a lot of animation on here, but if you just look at the top line, again, you have one group of patients on no prophylaxis. Again, this is inhibitor patients. And then group 2, concizumab prophylaxis. And the primary endpoint is that first row of white near the top, where it says treated spontaneous and traumatic bleeding episodes. So basically treated bleeds. And then the no prophylaxis group, you can see that it was 11.8. And in the concizumab group, it was 1.7. So the ratio was 0.14, which was obviously strongly statistically significant. And then you see similar outcomes of reduced bleeding rates, including for spontaneous bleeds, joint bleeds going from about 9 to about 1.5. So again, concizumab clearly very effective in Hem A and B patients with inhibitors. And here's the Hem A and B patients without inhibitors. This is the EXPLORER-8 trial. And so here, again, just looking at the table, we've simplified this a little bit more, looking at patients on no prophylaxis. And again, this was an international study, and I understand that most patients in the US without inhibitors would be on prophylaxis. But in this case, you've got patients on no prophylaxis compared to concizumab. And again, you see a significant reduction in the mean ABR from 19.3 to 2.7. And so ultimately, there was superiority of concizumab over no prophylaxis that was met in that clinical trial. And then the The full publication will be out soon. I neglected to mention that Explorer 7 was just recently published in the New England Journal of Medicine. If I go back one slide, you can see down there 2023, and the first author is Tadashi Matsushita, so you can have a look at that and get a lot more detail. The Explorer 8 manuscript is being worked on, so ultimately you'll see that currently it's only in the abstract form from ISTH last year. So marstacimab, this is another anti-TFPI inhibitor molecule. Now, I'll caution you here that this is data from a phase 2 trial. We have not seen yet really the full phase 3 data, although there was a recent press release I'll talk about in a moment. So here you've got lots of cohort doses. Of course, phase 2 is kind of like a dose finding trial, so that's why there's six cohorts, actually 5 cohorts, with lots of different dosings, including patients without inhibitors, patients with inhibitors. So it's quite a busy slide, but I'll just basically have you take a look at the pre-treatment ABR, which is in that top row just below the groupings, where you can see ABRs that are in the teens to low 20s. And if you go down to the next green colored box, which is the on-study ABR, the mean, you can see that it's a lot lower. Now again, phase 2 trials are really not meant for efficacy, but certainly you can see here that the marstacimab clearly had an effect, and that's what allowed it to move to phase 3. And the phase 3 basis trial is ongoing. It's looking at weekly dosing with just a loading dose of 300 milligrams, and that's taken from that phase 2 trial where there are multiple different doses, followed by a 150 milligram once weekly dose. It's flat dosing, it's not weight-based. So over 100 patients were involved in this trial, as you can see. And what was found, and this is, again, you see the reference on the bottom, it's just a press release. So I always take press releases a little bit with a grain of salt. It's not an abstract, which is at least slightly peer-reviewed, nor a manuscript, which is fully peer-reviewed. But at least in this press release, what was demonstrated was compared to on-demand factor replacement in these non-inhibitor patients, that there was a 92% reduction in bleeds. So similar to what you saw in fitusiran Atlas AB and in the Explorer 8 trial, where you saw this significant reduction compared to on-demand. As far as comparison to prophylaxis, there was a bit of a less reduction, a 35% reduction in annualized bleeding rates. Of course, patients on prophylaxis already have fairly low bleeding rates, but marstacimab was superior to factor prophylaxis. So I'm anxious to really see more of this data hopefully presented. I don't know if they're going to be presenting it at ASH, to be honest with you, but in some upcoming meeting. And the safety profile was pretty good. In fact, marstacimab has so far not had, to my knowledge, any thrombotic events. So anyway, the question is, which one of the following emerging agents for hemophilia A is a substitution therapy? Concizumab, marstacimab, fitusiran, Mymate, or MG1113. All right, so yeah, I'll start with a little bit of the teaching here, which is that, and this is semantics and language. So we have mixed results, and I think the word here is substitution therapy. So substituting for the missing factor. In this case, that's what we mean by substitution therapy. And so that really the answer there would be D, which is Mymate. The others are not substituting for a missing product. In fact, the other 4 would be in the category that we call rebalancing agents. Okay, so moving on to gene therapy, which is the last part of our talk, and hopefully we'll have a little bit of time for questions. I am cognizant that we're getting short on time. I'm just going to give you a little flavor here, that's all. So gene therapy in hemophilia A, essentially you can see in that complicated figure, but I'll just boil it down to we're putting the DNA, a functional copy of DNA for either factor 8 or factor 9. In this case, Hem A is factor 8. You put it into a vector, deliver the vector intravenously. The vector is targeted to the liver, hepatocyte. It uncoats in the hepatocyte, drops off the DNA in the nucleus, which then forms an episome, so an extra chromosomal piece of DNA, which is called an episome, which now has the DNA for factor 8, and then that DNA can get transcribed into through the ribosome to mRNA and then translated to a protein, and the patients hopefully can produce factor 8. And you can see the 3 products that are furthest along. In fact, aloctocogene roxaparvovec, which is an AAV5-mediated gene therapy, is now approved. It was licensed in late June, I believe, so a few months ago. and it is available for prescription. The next one that will likely be licensed, I don't know exactly when, but I believe it'll be sometime in 2024, is giroctocogene fitelparvovec, and that's still, I guess, in the phase 3 stage, and that is a AAV6 combo with AAV2 vector. And then the SPK8011 molecule, which uses a proprietary vector from Spark called AAV Spark 200. That's a little bit earlier phase than giroctocogene fitelparvovec. And so here's the data for the GENERATE-1 trial, which is the phase 3 trial. So the left panel is the change in factor VIII activity. You can see that through about week 24, maybe week 26, about 6 months, factor VIII levels are rising to close to the normal range. So the diamond is a box and whisker plot. The diamond is the mean. The straight line inside the box is the median, and then the box is the interquartile range, and then the ranges are the error bars. So you can see there's quite a bit of variability in between patients, even including an interquartile range with patients around 20% to as high as about 70%. And this is based on a chromogenic factor VIII assay, by the way, so not the one-stage clotting assay. And then over some time, you start to see a drop-off in the factor level through year 1, which we don't show here, but does continue through year 2 and year 3, albeit it's a slow but steady drop-off. As far as bleeding episodes, you can see that bleeding almost stops. The medians are 0 if you look at the right panel, the left side of the right panel. And then after the baseline, compared to from baseline to after the infusion. So you've got a median of 2.8 to a median of 0, and a mean of 4.8 to a mean of 0.8. And factor infusions, the right side of the right panel, you can see pretty much goes to nothing. So these patients are not infusing factor and they're not bleeding. And that's because they have a factor VIII level that is providing them therapeutic benefit. There's been a lot of use of immunosuppression. You can see that almost 80% of the patients needed some immunosuppression due to increased ALT and AST, which may mean a sign of an immune response against the cells that have been transduced. And so that's where the steroids come in. I think there's still a lot to learn about how we're using the steroids in these patients. So I think stay tuned for that. And I unfortunately don't have time to really get into those details. What we can see here in terms of the factor VIII levels, and again, these are chromogenic assays, is that by year 3, first of all, 92% of the patients are still off of prophylaxis. So that does mean 8% did return to prophylaxis. And if we look at the mean activity, mean and median, the mean is around 18% in year 3, 15% in year 4, and the median is still about 8% in year 3 and 7% in year 4. So factor levels do drop, but you can see the vast majority of patients are still remaining off of prophylaxis. And those who did have to go back onto factor VIII prophy or emicizumab were able to do so safely. And just very briefly, just the phase 1-2 data from giroctocogene fitelparvovec. We don't have the phase 3 data yet. Again, it's a phase 1-2, so it's a dose finding and safety study. If you just focus in on cohort 4, which was the highest dose cohort and the cohort that got translated to the phase 3 study, you see 5 patients there. And you can see that their pre-infusion ABR was 8.8 in the white row there. And then the row below, you can see the post-infusion ABR was 0.7. So essentially, we're seeing responses similar to what we see for valoctocogene roxaparvovec. There's a lot more data on this that I don't have time to get into. Suffice to say that the data are quite similar between this molecule for what's so far been published and valoctocogene roxaparvovec. So getting to the end here, this is where we are with factor-based therapy, standard half-life and extended half-life we've been had for a long time. Heard about FNS octocog alpha. Those are all available now. There is this oral pill that's being worked on now. I haven't heard much on that lately. It's basically a robotic pill that injects factor VIII into the intestine with little tiny needles. Not sure that'll eventually make it. In the non-factor therapies, you heard about emicizumab, and that's already available. That's why it's in the dark color in red. I say soon because I think in the next year or two, we will see Mymate. NXT007 will take a little longer, but fitusiran and concizumab are likely to come in 2024, maybe marstacimab a bit later and serpin-BC a bit later. And with gene therapy, we have valoctocogene roxaparvovec, and I believe next year we'll have giroctocogene fitelparvovec. So which one of the following agents is a novel replacement therapy for hemophilia A? So your options are, and again, which is a novel replacement therapy for hemophilia A? Is it emicizumab, concizumab, marstacimab, fitusiran, or valoctocogene roxaparvovec? Okay, and everyone got the right answer. Fantastic. A couple cases. I think we're running out of time, so I'll probably be very brief here. So we've got a 6-month-old. It's having lots of trauma-related bleeds, including mouth and tongue. He's gotten multiple doses of Novo-7 because he's had an inhibitor. And then you can see he's developed this factor VIII inhibitor after just very few doses, and immune tolerance was not attempted. And he started having, so now he's 2 years old, and he's having joint bleeds in his ankles and his knees, requiring a lot of Novo-7. And so now at 2 years of age, he's been on, he hasn't tried ITI, and we're still trying to get him to have his bleeds under control. So I guess here, which of the following options would be the best practice approach for you? And we'll let you go ahead and vote. You can see your options are efanesoctocog alpha, emicizumab, fitusiran, concizumab, and valoctocogene roxaparvovec. So essentially, 2-year-old with an inhibitor with multiple bleeds on Novo, despite getting Novo-7 for treating the bleeds. And now he's having joint bleeds. And looks like B is basically the number one answer here. And that's obviously the correct answer. So well done to you all. And then now, moving along here, this patient is now, as he actually started fitusiran prophylaxis. Now that was on a clinical trial, obviously, and he's done well with that. Let's get to the next case. I think that's more valuable. So we have a 13-year-old boy. He's got 3 target joints, knees, 2 elbows, and a knee. He's been wheelchair bound at times. He has an ABR of about 20 over the past several years. Now, he has an allergic reaction to factor VIII, and for that reason, we've had to rely on factor VIIa to treat him. And on occasion, he was provided factor VIIa for bleed prevention, but it wasn't really working very well. So what would be the best practice option for this 13-year-old boy with severe hemophilia A, noting he has an allergy to factor VIII, he's bleeding a lot. Novo-7 is controlling the bleeds, but he doesn't have a good prophylaxis option. So let's go ahead and vote. Your options are efanesoctocog alpha, emicizumab, fitusiran, concizumab, and valoctocogene roxaparvovec. Yeah, certainly emicizumab would be an excellent option. I think here, depending on what's available, emicizumab or fitusiran or concizumab. Of course, he has this allergic reaction, so efanesoctocog wouldn't be an option. He's too young for gene therapy. So any of those 3, and of course, the one that's available now is emicizumab. So in this case, yes, emicizumab would have been the best option. Turned out that because he's in my center, he gets options for clinical trials, and this family was interested in clinical trials, so he was started on concizumab. He's actually done really well. He's out of the wheelchair. He's not bleeding, and so he's done as well as what you saw in the Explore-8 trial, with his bleed rate going down very low. And then finally, a 40-year-old man, so it's an adult. He manages his prophylaxis well without many missed bleeds, but he still has 4 to 6 joint bleeds per year. He really wants to minimize these bleeds. He switched to an extended half-life factor VIII at relatively high doses, but he's still, still having some bleeds. You can see his background is he's had moderate hemophilic arthropathy. So back to the polling question, again, with the same options you had in the previous question, what would be a best practice approach for this patient? Again, the options are efanesoctocog alpha, emicizumab, fitusiran, concizumab, or valoctocogene roxaparvovec. Yeah, I think those are good options. I think, again, really almost any of these options could be considered for this patient, but I think in an adult patient who's really looking to really get bleeds under control, perhaps even improve quality of life, he was offered gene therapy in a trial, and he ended up on valoctocogene roxaparvovec. So in the near future, as we get to the teaching point here, there'll be multiple new therapeutic options for persons with hemophilia A. And treatment decisions are going to be more complicated, right? When you have more options, it's more complicated. I use the analogy of, if you're going to go to a Subway, well, you don't have too many choices. You're going to pick a sub and put whatever meat you want in there. But if you go with a group of people to a restaurant that has, I won't advertise any, but that has multiple menu options, it can be more complicated. Do I want the fish or the steak, or last night I had pasta, maybe I want something else. So yeah, as the menu gets bigger, the decisions are going to get bigger. And the key point here is to follow a shared decision-making approach. You see one of them there, which is the SHARE acronym: seek your patient's participation, help your patient explore and compare treatment options, assess your patient's values and preferences, and then reach a decision. And after you reach a decision, of course, you have to evaluate the response to the decision and then move forward from there. And don't be afraid to give one therapy and then switch to another. The caveat there is, of course, gene therapy cannot be undone. So once you have the gene therapy, it's there. But again, if a patient does lose their response, they can go back on prophylaxis. So I think with that whirlwind there and trying to finish more or less on time here, I will stop, and we're happy to take some of your questions for me or Angela. Which other clinical trials are underway for emicizumab and efanesoctocog?
Yeah, so you probably know a little better than I do. I know there are a number of investigator-initiated studies for emicizumab, like in von Willebrand's disease and looking at sports participation. And then with efanesoctocog, I know that there's interest and planning for trying to collect data in POPs, which is the population they don't currently have really any data on, as well as using efanesoctocog, like in von Willebrand's disease. But you probably know a little better than I do of others.
Yeah, no, I think you covered it. As you said, there's quite a number of investigator-initiated studies that have been funded by Genentech for emicizumab. You've mentioned a couple of them. And then really the main trial that's newer that's going on, you covered as well, which is HAVEN 7. If people are wondering what happened to HAVEN 5 and 6, sort of like what happened to Factor 3 and 6, HAVEN 5 was a study that was done in China. So it's a Chinese-only study, and it was required by the Chinese government to get approval there. And then HAVEN 6 was a study in mild and moderate hemophilia, which was really done mostly for Europe, because in Europe, the label was only severe hemophilia, and the European Medicines Agency required a study in mild and moderate hemophilia patients. In the US, we already had that approval, so it was less important for us, although some people did participate in that. So that's HAVEN 5 and 6. I'm not aware of any HAVEN 8, and HAVEN 7 may be the last one. And I think for EFA, yeah, I think this is the time that people who are interested in the drug should really think of ideas for studies. I think the most obvious example, although it would be challenging, would be emicizumab versus efanesoctocog alpha, and looking at various, not just, bleeding is going to be low for both, but looking at some other aspects, whether it's quality of life, whether it's activity, sports participation. It probably needs to be something like that done, because we don't have that head-to-head, two different mechanisms of action, kind of two different ways that the drugs, their pharmacokinetics work. EFA still does have peaks and troughs, although the trough is quite blunted, as you showed. Emi's flat. So I think that would be pretty interesting.
Yeah, I think that's what we would all like. Someone can do that. That would be great.
Yeah. It would be a challenging study to do, no doubt, but I think that would be interesting. Last question here is, can any of the new rebalancing agents be used in combination with other agents? I can take that one on first. I in a talk I gave a little over a year ago, I actually conjectured that we might start using some combination therapy. And at the basis, why do we use combination therapy in other diseases? Well, the reason, those of us who, I don't really do oncology anymore, but most of us on here have done oncology at some point or still do it. The reason why you do that is that you're using drugs with different mechanisms of action to try to have a better impact on the disease, so improve efficacy, and drugs we don't have overlapping toxicities, so you get less toxicity. I think in hemophilia A, we are going to start to see some of that. And in fact, I would argue that we are seeing it in some patients who have received gene therapy. So some patients on valoctocogene roxaparvovec, their factor levels are not undetectable. They're still detectable, and yet they've had bleeding. So they've started back on some sort of product. So they're kind of on some sort of combination therapy. But if the question is really about, can you use emicizumab and fitusiran together, to improve the efficacy. That's something that we're actually looking at, in my lab to try to understand, what is the impacts of these two together in vitro. I absolutely, first of all, fitusiran is not available. Even when it becomes available, you absolutely should not combine the two. Let me make that crystal clear. Don't combine the two unless you're doing a clinical trial. But yeah, I think that we may get to a point where, if we're not getting the full satisfactory response, we may use them in some sort of combination, maybe less often, maybe at lower doses. So I think there's a lot to learn about that, and it'll be interesting to see how that transpires. But I think the main message is they have not been studied in combination. They're not going to be studied for the nearest future in combination. And when they're available, I would not advise doing that outside of a clinical trial. All right, well, thanks everybody. And I think that'll be it. And have a good evening or late afternoon if you're on the West Coast like me.